Imagine securing the funding, hiring the medical staff, and finding the perfect location to open a new health clinic. Now imagine the government telling you that before you can treat a single patient, you have to ask your biggest competitor for permission. That is the reality in 35 states across the U.S. that enforce what are known as Certificate of Need, or CON, laws. Under this system, healthcare providers cannot simply open a new facility, expand an existing one, or buy certain medical equipment. They have to prove to a state planning agency that the community actually needs it. This map shows the varying application fees states charge to submit a proposal. While some cap fees at a few $1,000s, others demand over $100,000 just to be considered. In Kentucky, fees easily reach six figures, and in Hawaii, formulas are entirely uncapped. And the state fee is usually just the beginning. To navigate the complex completeness reviews, applicants regularly hire specialized consultants and lawyers. Those startup costs can easily reach $300,000, trapping providers in a bureaucratic process that drags on for months or even years. But the biggest hurdle is what happens after the application is filed. This map highlights the states that allow the competitor's veto. This is a legal mechanism that gives existing incumbent hospitals the right to formally intervene, present evidence, and actively oppose a newcomer's application. This chart breaks down what happens when that veto is used. When an application goes completely unopposed, it usually passes. But when an incumbent hospital decides to fight a new clinic's application, the denial rate spikes to 57%, and the entire decision timeline doubles. By combining steep financial entry costs with a legal veto for incumbents, the CON process effectively protects the territory of established hospitals. Blocking a new facility doesn't make the local need for healthcare disappear. If a community's population grows, but a new clinic is denied permission to open, those patients are forced into existing infrastructure, leading to overcrowded emergency rooms and much longer wait times for basic care. The trap catches the incumbents, too. If an existing, overcrowded hospital wants to alleviate that pressure by adding new beds or purchasing a piece of high-cost equipment like an MRI machine, they also have to enter the CON application gauntlet. When hospitals face fewer competitors and heavy restrictions on expanding their physical footprints, their operations suffer. Economic data shows that hospitals in these highly regulated states operate with higher costs per unit and lower overall efficiency. This pricing logic explains why a lack of competition doesn't lead to runaway costs for patients. Unlike a standard monopoly that can charge whatever it wants, hospital prices are largely locked in through government programs like Medicare and negotiations with private insurers. This structure prevents the unilateral price spikes seen in unregulated markets. But while the final price tag might be capped, the lack of competitive pressure has a secondary effect. Without the threat of new clinics offering faster or cheaper alternatives, the underlying cost of delivering that care increases. It creates systemic bloat. So, if these laws create bureaucratic bloat and trap incumbents, why do states keep them? The primary defense rests on the safety net shield theory. Large community and rural hospitals operate essential services that constantly lose money, like emergency rooms, burn centers, and psychiatric wards. They keep the lights on by cross-subsidizing those losses with profitable procedures, like knee replacements. If a specialized boutique clinic opens next door and poaches lucrative surgeries, the community hospital might go bankrupt, taking the local ER down with it. Data backs this up. Studies indicate that rural hospitals in states with CON laws are slightly less likely to close down or shut down essential, unprofitable departments. The healthcare system is essentially making a trade. It guarantees a level of financial stability to those vulnerable rural hospitals, but pays for it by imposing statewide operational inefficiency and strictly limiting where and how new care can expand. We know how this affects hospital bottom lines and state bureaucracy, but does trading market efficiency for institutional protection actually result in better health for the patient? This chart compares the strictness of state CON laws against patient outcomes. For major surgeries performed exclusively inside hospitals, like coronary bypasses, the data points downward. States with strict CON laws are linked to worse mortality rates for these critical procedures.
But look at what happens when we chart outpatient care and hospice facilities. In these smaller settings, states with con laws frequently show better patient outcomes. This happens because the review process acts as a safety audit. Regulators often require applicants to prove a history of high-quality care and show they have specific protocols in place, like emergency transport plans for surgical complications. This gauntlet filters out under-resourced or substandard providers who might otherwise skip these safety precautions. When you pull all the data together, the picture is complicated. These laws do offer a lifeline to vulnerable rural hospitals and provide a quality filter for outpatient clinics.
But they'd achieve this by driving up administrative bloat, reducing overall hospital efficiency, and worsening outcomes for the most serious hospital-based surgeries. The con system offers stability to existing hospital business models, but it does so through a rigid market that often prioritizes institutional inertia over the health and wallets of the average patient.